Good morning. Good morning. This is like lecturing where you have to jump up and down to get the students' attention. Good morning. Well, good morning and welcome. My name's Eileen Denovan Wright. I'm the Associate Dean of Research in the Faculty of Medicine. And I want to thank all of you so much. What a great turnout this morning. It was sunny, so that helped. But I really want to acknowledge that, we really appreciate the gift of your time for coming to join us to talk about this important issue. But before we begin, I would want to acknowledge that Dalhousie Medical School sits on the ancestral, unceded, and unsurrendered territory of the Mi'kmaq Nation. As peace and friendship treaty beneficiaries, we have a responsibility to continuously educate ourselves and work in solidarity with Mi'kmaq and other Indigenous communities. We also recognize the histories, contributions, and legacies of the African Nova Scotian people who have been here for over 400 years. This event is designed to celebrate groundbreaking research and medical innovation. We have a whole series of the Breakthrough Breakfast showcases in different areas of medical discovery, featuring Dalhousie researchers at the forefronts of their fields. Today, we'll be highlighting cutting edge advancements in youth mental health, including digital apps co designed with youth to promote wellness and motivate behavioral change, youth centered approaches to care, the importance of translating research into clinical best practices, and early intervention and diagnoses. Attendees will gain insights into how this research helps our partners improve diagnosis, treatment, and support systems for young people facing mental health challenges. I'd like to extend our sincere gratitude to our sponsors and partners who make events like this possible. Our gold sponsor, Shanex, is a family owned organization with a vision for leading the way to better living. Our silver sponsor is Dalhousie's Department of Medicine, dedicated to building a healthier tomorrow together through our commitment to excellence in quality care, research, and education. And our bronze sponsor, Kids Help Phone, Canada's trailblazing 24/7 e mental health solution and a global leader in youth mental health innovation. Please visit the expo booths that are in the back area to explore demonstrations, gather information and materials, and pick up some swag. Don't forget to grab your copy of the latest issue of Remedy magazine, featuring inspiring stories of research, education, and philanthropy in the Faculty of Medicine. I hope you get a chance to meet some of the amazing young people that are manning those booths. They've really come today to and are excited to be able to speak. Please enjoy your breakfast and continue to keep eating. We're going to enjoy our breakfast, and I would like to invite the Dean of Medicine, Dr. David Anderson, to the stage to say a few words.
Thank you, Eileen. Good morning, everyone. Really a pleasure to be here and really excited to see so many of you turn out for this really important event. I want to special mention to Honorable Member Lisa LaChance, who's member for Halifax Citadel Sable Island. Thank you for joining us this morning. Dalhousie Faculty of Medicine is at the forefront of youth mental health research, a critical research area that demands our attention. Early intervention can make a difference in the lives of people, and research in this field is vital to developing effective strategies and treatments. Today, we have an esteemed lineup of speakers who will share their insights and research findings. Dr. Rudolph Uhr is a Canada Research Chair in Early Intervention in Psychiatry and a professor at Dalhousie. Dr. Sandra Meyer is a Canada Research Chair in Developmental Psychopathology and Youth Mental Health and is an Associate Professor in Psychiatry at Dalhousie. Dr. Jill Chorney is a clinical psychologist at the IWK and an Associate Professor in Psychiatry. And Dr. Lori Wozni is the Sun Life Youth Mental Health Chair based at the IWK, an Assistant Professor in Psychiatry, and the scientific lead for anchor youth spaces in Nova Scotia. Our researchers, the IWK, and this region's healthcare providers are working tirelessly to find and implement solutions in the area of youth mental health. We're so grateful for their hard work, ingenuity, and passion for youth mental health, and we're proud of the strides that have been made right here in Atlantic Canada. Thank you for joining us today, and I hope you're looking forward to hearing from our speakers this morning as much as I am. Thank you very much.
Thank you, Dean Anderson. All right, let's jump right in. So I'm pleased to introduce our first speaker, Dr. Rudolf Uhr. Dr. Uhr is testing early interventions to prevent mental illness and personalized treatments for depression. He leads the Families Overcoming Risks and Building Opportunities for Well-Being, or FORBO, as we refer to it. The treatment interrupt depression early, TIDE. He has a lot of great acronyms. He spends a lot of time on these. And the data science platform of the Canadian Biomarker Integration Network in Depression, CAN-BIND. So Dr. Uhr's research has been supported by many donors, including the Medavie Health Foundation, Hewitt Foundation, Waverly House Foundation, Aberdeen Health Foundation, the Sutton Family, Gallant MacDonald, the Windsor Foundation, and the IA Financial Group, and many others. Because of this generous support, he's been able to do amazing work, and we can't wait to hear what's the latest. So please join me in welcoming Dr. Uhr. I'll give you 10 minutes and I'll walk towards you, okay?
Yes. Thank you. Well, thank you everyone for coming. It's absolutely wonderful to be here. Beautiful morning. I'll talk about depression. But I'll start with a question. How many teenagers or adolescents are there in Canada? Any guesses? Have your own. You know it, yes. Yeah. Depends how you count. It's between 3.5 and 4.5. So that's not the shocking fact. The fact is 600,000 of them get prescribed an antidepressant every year. And these are recommendations, so typically starting a new antidepressant. So that would, you are adolescent for 7 years. And every year, 1 in 7 adolescents gets an antidepressant prescribed. That's a lot. Especially considering that actually how many treatments has Health Canada approved for depression in people under 18? 0. So all this is off-label prescribing. This is actually the biggest case of off-label prescribing in Canada. And 1 in 6 adolescents, 1 in 8 adolescents gets antidepressants every year. The initial reaction by most people, oh yeah, it's there. Too many. How comes? It shouldn't be. They are kids. And why don't they get therapy? It should be available. That's the initial reaction of people. But the other reaction is too few. That's what we get when we see all the people who have been out of school for months or years without getting treated because of the untreated depression. So we have this, possibly there's a mixture of overtreatment, undertreatment. I think there's actually more undertreatment. And what these numbers tell us, depression is very common. Depression is actually the most common reason not to finish school, not to get qualifications, not to enter workforce or be able to hold a job, or not to start a family, right? You hear a lot about other illnesses, other mental health problems, but depression, by being so common, is actually responsible for the bulk of harm. Starting anywhere from age 10, depression is the #1 impairing condition causing disability in young people, and actually going through most of the lifetime. And when does it start? the age when depression starts most often in the entire life, 16. So that's why I'm talking about teenagers, right? That's when it happens. And it keeps affecting people for a long time, and that's why it's so impactful, so burdensome. That's why I'm working on it. So what are we doing about this? This is not good. Well, we're trying a lot. So often the first question, someone develops depression, should they get psychotherapist? Should they get antidepressants, right? The pendulum swings with time. Right now, psychotherapy is the kind of wanted choice. You expected to say, I prefer psychotherapy when you ask what you prefer. Then when people actually have to choose, they sometimes make quite different choices. But it's an important question. A specific person with depression, will they improve with CBT, psychotherapy, or do they need antidepressants? So these are data from here, from Nova Scotia, Depression Clinical Research Program, expo table over there for details. We're treating people with the best treatments. The only condition is the initial treatment choice, it's random, we throw a dice. So these are entirely comparable groups of people with major depressive disorder who get randomly allocated to either antidepressant or psychotherapy. And it's the number is on the bottom is weeks. So we treat them for 16 weeks, best possible treatment. And they start in the same place and they end in the same place. Like the axis going up is depression. So you want the lines to go down, they go down, that's a good stuff. They don't go down to zero. That's not a good stuff. That means, some people do improve a lot and some people not so much. And the groups that you give antidepressant and CBT, they end up in exactly the same place. So is it as effective as possible? Well, yes and no. When you look in the middle, right, in the initial 6 weeks, the group getting antidepressants are doing substantially better. So antidepressants work faster to get you out of depression. But the CBT has long-term benefits. The antidepressant you have to continue taking. Like the CBT, you keep benefiting even after you stop seeing the therapist because you train so much. But that's not the interesting stuff. The interesting stuff is what works for whom, or personalized treatment. Because there are some people who really wanted therapy, they tried their best and they don't get better until we give them the antidepressant. And there's the opposite. There's people who do beautifully with therapy. And we found that persistent course of illness and also metabolism, insulin resistance, kind of pre-diabetes, those are strong indications. If you have those, you need an antidepressant. You will not get better with CBT. New finding from Nova Scotia. We're taking it further because it's nice to personalize treatment. We want to personalize the first treatment people ever get. To get complete remission, lasting remission from depression the first time you treat it. So typically these are young people. We're doing this age 12 to 25. And here we're using a set of biomarkers, objective measurements. Some adolescents don't tell you so much, so it's good to do objective measurements. We measure brain activity, speech. We can estimate depression from speech as accurately as from half an hour interview, from 1 minute speech. And actigraph, like Fitbit. And you can see that the lines from before treatment to after treatment, they get livelier, right? That's people getting better. But these measurements also help us select which treatment a young person needs so that they get better immediately. The difference between getting better with first or third treatment may be whether you're finishing high school with your peer cohort. So that's happening right now in Halifax and newly also in Quebec. So we just opened a second site in Montreal with support from several foundations. Some of them are here. Well, moving forward, people who don't get better with CBT or an antidepressant, the best next bet is trying an add-on, 2 medications together, right? Not what people want. We talk a lot with people living with depression, what they want. And one say, well, no one wants medication in the first place, let alone 2 medications. But if you tell me that's what I need to get better, I want it straight away. I don't want to wait to fail several treatments before you give it to me. So that's what we're testing right now. So Optimum D ran across 9 sites in Canada, led from here in Nova Scotia. We comparing combination to single antidepressant treatment. You can see the people on combination are on average doing better. That's the red line. Going deeper is better. And again, that's not just saying everyone needs 2 medication. That would be the wrong thing to do. It's about who needs what. So in this case, we're using symptom profile, including activity, and we're using brain function measured with EEG, and bring those together in an algorithm that tells people who needs what. And that algorithm is being tested for improving outcomes of depression right now in the biggest trial ever done on depression in Canada. But even better would be not to have depression in the first place, so it can be prevented. And here Forbo comes in, my baby project that we've been running with Alexa and others for 13 years now. And in Forbo, we follow up young people actually from babies and through adolescence. I just saw another one yesterday, and they say, they've been coming here over a decade. Isn't that strange? I say, that's wonderful. Thanks for the loyalty. That's really where the real data comes from. It takes time. And we test many things in Forbo, but the one I will highlight today is depression is predictable. The bar chart shows you young people who had 0, 1, 2, 3, or 4 of antecedents. These are like early signs of risk that we can get from interviews and testing on annual monitoring checkups. If they have 0 of them, their risk of depression is around 1%. If they get all 4, the risk of depression is about 12% per year. That's a lot. But it's also a big difference. So if we focus on those with antecedents, we can prevent most cases of depression if we have an effective intervention. And targeted interventions are more effective than universal intervention when it comes to depression. So that's what we're doing. We call it SWELL, Skills for Wellness. That's one acronym that Eileen forgot to mention. And we using what we know what works, which is CBT, cognitive behavioral therapy, except it's not therapy, it's coaching. Because these are not patients we're preventing, we're not treating here. And this is another long-term project that will take another decade to show what it's actually doing to reducing depression and other mental health issues. 180 kids allocated to SWELL so far, all from Forbo. So the idea is together monitoring, prevention, early personalized treatment, and advanced biomarker-based therapeutics will lead to something like this. For the first time ever, I hope to get headlines that the burden of depression is actually not rising, but declining. My guess is 2035. Thank you. You want me there?
Thank you very much, Dr. Orr. We could have listened to many of those studies longer, and I'm sorry I forgot SWELL. I do apologize for that. There's a lot of acronyms. So that was really interesting. I'd now like to welcome Dr. Sandra Meyer to the stage. Oh, there she is. Great. Dr. Meyer leads the PROSIT research study, predicting risks and outcomes of social interactions. Her research focuses on leveraging mobile technology to improve youth mental health care with a strong emphasis on co-designing digital interventions with young people. Dr. Meyer has also developed several mental health apps, integrating mobile sensing and AI for early detection and tailored interventions in youth mental health. She'll be telling us about some of them, and then you can learn more and try them during the expo at the back following today's presentation. So welcome, Dr. Meyer.
Okay, thank you so much. I'm very excited to speak to you today about some of the research that we're doing with youth. And as you can see, we majorly work on developing novel interventions. And let me tell you why we're doing that. So it's true we have a lot of great services out there, but sadly only 20 to 30% of youth that need mental health care get it actually, which means the majority of them won't. And these youth we know are at a higher risk to develop depression, bipolar disorder, schizophrenia, and some of them may even commit suicide. So why is that happening? Why don't youth access care? There's a lot of reasons for that. Let's imagine you're 16 years old, you have been struggling with anxiety for weeks. Some mornings it's really hard for you to get out of bed. Let's now think about getting care. You don't have a family doctor, your school nurse seems overwhelmed, your parents don't really talk about mental health, you've heard about therapy, but you have no idea how to get it. And to talk about anything that you're going through with a complete stranger seems simply overwhelming. This is the sad reality for far too many youth in Canada every single day. This is just the example of one of our patients. It's not that they don't want care, it's just that they experience a lot of barriers in accessing it. Mental health apps have the potential to change that because they can meet youth where they are on their smartphones. Whether we think that is good or bad, we can reach them there. It can be held in their palm. Many youth don't access traditional services because they fear they're going to be judged. Mental health apps can create safe and stigma-free spaces in which youth can learn, reflect, and grow on their own terms. And this perceived safety can be the first step towards healing. Mental health apps are also highly accessible. It doesn't matter whether youth lives here in the city of Halifax or at the outer skirts of Cape Breton. We can support them over mental health apps instantly, and we can support them day or night whenever they need support the most. Let's say during a sleepless night or a tough school day, they can integrate into the daily life of youth in a way traditional services simply can't. And mental health apps can be highly scalable. When we get one well-developed app, we can reach thousands, when not millions of youth. So this all sounds extremely exciting. So what's the problem? Yes, we have thousands, when not 10,000s of mental health apps on the market. But sadly, most of them are developed for profit and won't even work because they fall short in the following ways. Many of them lack scientific validation. It's actually less than 1% of the thousands of mental health apps out there that have some kind of scientific background. Okay? So many of them just skip rigorous testing to get faster on the market. But that means that youth get advice and interventions that are not proven to work, or even worse, they may actually cause them harm. In addition, many mental health apps are not co-designed with the very people they claim to serve. Youth deserve a seat at the table. If we don't include them in the design of mental health apps, these tools are very likely not going to engage them. And finally, many mental health apps are quite generic. They offer a one-size-fits-all solution. But when you think about mental health, if we don't consider youth's identity, experiences, and individual needs, you will very likely miss the mark, but also the very youth that we aim to help. So this is why my lab has a different approach. First of all, everything that we're doing is evidence-based. Every single feature that we develop is rooted in clinical science. And we test our apps rigorously for months with youth to ensure that they work in reality, in daily life. We also design with youth, not just for them, which means we work hand in hand with youth through advisory council, co-design sessions, and we have constant feedback loops with them to ensure that the mental health apps that we develop reflect their voices, needs, and experiences. And finally, we work a lot on personalizing content because every single youth's experience of anxiety and depression can look quite different. But to personalize mental health care, we need data and we need a lot of it. But let's be honest, we can't really ask a youth to talk about their mental health with us every single day. They will not fill out a questionnaire every morning or every evening, even if I really would like them to do that. And it's even less likely that they do that when they're already struggling. So we are stuck in a kind of loop. We need more data to personalize mental health care, but the very people we aim to help can't or won't give us the data we need to do that. So this is where most traditional mental health apps fall short and where innovation can step in. We do that over mobile sensing. It's not very different from the smartwatch that I'm wearing and some of you might be wearing too. That tells you a little bit about your activity during the day. We do the same, just using the built-in sensors of a smartphone to learn about the youth's sleep, physical activity, screen time, and many, many other things. And we do that with the youth's permission and built-in privacy protection. And with that data, we know what's happening in a youth's life in real time out there without asking them to do actually a lot. Okay, and this is already happening. It's not just a theory. I'm doing that all the time. We actually have done mobile sensing with thousands of youth. And that allows me to provide the right support to the right people at the right time. And I hope this is working now. I would love to introduce you to the Smile app. It's one of the apps that we have co-designed with youth with severe anxiety. You can see here the screen. It has a lot of features, and one of our youth advisors using it. And once Smile has identified the problem via mobile sensing, in this case, it's a sleep problem, which is very common in anxiety disorders. Once the app has identified that, it gives a few tips around sleep, how you can improve it, but it majorly tries to motivate youth to set a goal to work on their sleep. And you can see we have a pre-written goals to just give some ideas, but youth can also generate their own goal. And once they have set their goal, we ask them to also set a date by which they want to have achieved that goal. And once that day has arrived, the app checks back in with them and asks them whether they have been successful. So this is one way how we personalize the Smile app. But we also allow youth to completely change its design by changing the font size, by changing the color, by changing the picture that it shows. And we do that so that youth really feel it's their app, that it speaks to them, that they are in control. And by that, we hope to increase their engagement. So how well does the Smile app actually do? Can we improve anxiety and depression with the Smile app? So we conducted a randomized controlled trial with 111 youth. Some of them got the Smile app, some of them got a very similar app, but that wasn't supposed to actually improve anxiety. And what we saw was that Smile had a strong impact, and quite immediately, on both anxiety and depression already after 4 weeks of usage. And even better, once youth actually had stopped using the apps, 3 months later, we still saw a significant improvement in anxiety and depression. So this means that Smile is actually one of the most efficient mental health apps out there on the market. It outperforms the majority of mental health apps, especially for youth, that exist very few validated ones. And it's not only its impact, it's also its efficiency. We saw that we can achieve 50 to 60% what we see an in-person improvement in a much, much shorter time frame. You actually need 8 to 10 times less time than traditional therapy. So this makes us extremely effective. In addition, we saw that we can reach the very youth that we normally don't see in traditional services. Actually, 40% of its users identified as racial, gender, or sexual minorities. This is the youth we often miss. So we were beyond these first results of the Smile app, but we also have a very ambitious goal. We want to make Smile as responsive and as effective as in-person care, and that is really an ambitious goal. But let me tell you how we hope to get there. So first of all, we would like to increase access to it, especially for youth that have traditionally faced barriers to care, and we hope to make it more interactive, to get more usage and to get more engagement. We have seen that when we add guided components to e-health solutions, we actually get the same response as by in-person care. So we hope to add structured messaging, chatbots, but also real-time messaging with clinical healthcare professionals. And by doing that, we hope that you feel more supported, seen, and we can also keep them a little bit better on track with exercises when we have a guided component. And finally, we hope to integrate it in the current healthcare system. Smile can be a very powerful companion for youth who already receive care because it can help them transition what they learn in sessions out there into their real life. And by doing that, he not only hoped to boost the recovery of youth with CD anxiety, but also hinder the development of other illnesses like depression, bipolar disorder, schizophrenia, or even suicidality later in life. Thank you so much.
Thank you, Dr. Meyer. I look forward to the demonstrations, and also I will remind our audience that we're going to have our panelists come back up on stage so you can think of your questions beforehand, and we won't interrupt the flow of the talks in between. So please join me now in welcoming Dr. Jill Chorney to the stage. Dr. Chorney's research interests are in the area of shared decision-making, patient-provided interactions, and behavioral change. She is one of the principal investigators of a $7.5 million focused research investment grant from Research Nova Scotia. As scientific lead for the Mental Health and Addictions Program at IWK Health and Director of Research for the Division of Clinical for Child and Adolescent Psychiatry, Dr. Chorney is deeply committed to connecting research and care delivery to improve mental health outcomes for youth and those who support them. So welcome, Dr. Chorney. I'll walk towards you when the
Good morning, everyone. Thanks for the opportunity to have a conversation today. As Dr. Donovan Wright mentioned, I'm Jill Chorney. I'm a clinical psychologist by training, and I care a lot about getting research into practice so that it has an impact for the patients who need it. Let me tell you a little story from early on in my training for why this became so important to me. So my story starts actually probably about 25 or so years ago when I started graduate school. And at the time, I wasn't working in mental health. I was working on some research that was looking at how we helped kids cope better with vaccines. And we did a scientific study. So at the time, there was a new spray available that helped to numb the skin faster than what was on the market at the time. We did a good clinical randomized control trial. We randomly assigned some of our patients to get the spray, some of our patients to get distraction, and some of our patients to get standard care at the time, which was parents holding their kids on their laps. The good news was we had good findings. So out of this research, we found out that the spray actually helped kids cry less, helped them feel less pain, helped them cope better, and the distraction actually worked pretty well too. So we had good news out of the study. We had two things that could work to help these kids cope with pain. As a good graduate student does, I published my findings. I was very proud of myself. My mom saw my name in print. It was great. We were cited by other researchers. Other researchers built on the work that we did, and the research continued to go. So I thought this was great news, right? Good work. Here's the trick. I popped in to the vaccine clinic about 8 months after we had done this work. I got really close to the nurses, as you can imagine, collecting data any graduate students in the room know, collecting data every week. You get very close to the clinical folks who you're working with. And I asked how things were going. And their news was, well, Jill, you know what? You know that spray that worked so well? Well, we can't really get it through procurement, and it's not really a priority for some of our purchasers right now. And by the way, that distraction that worked really well, it's sitting in our cupboard because it's hard to clean. And when you're not here to set it up for us, we can't use it. Incredibly disheartened. This was my first graduate student experience of doing some great research and learning, if anything, that the important thing is actually then how do we get it into practice. So unfortunately, my experience was not uncommon. You may have heard this statistic before. It can take up to 17 years to get research into practice. And actually, 50% of the things that we try to implement in healthcare don't give us the benefits that we thought, right? We might think, oh, those healthcare people, they're challenging, right? Why don't we just make changes? Well, let me ask you a question. How many of you in this room set a New Year's resolution? You're gonna out yourselves? Put up your hand if you did. Okay. How many of you, I love asking this question this time of year, how many of you are still doing your New Year's resolution, right? Change is not easy, people. Change is hard. And when it comes to applying research in practice, we have to pay attention to change. And we have to pay attention to how we move research into practice. So what does all of this have to do with mental health? Why am I talking about this when I'm standing up on a stage on a mental health day? Well, the truth is we have many really useful, helpful, important interventions that are coming out of research that we need to implement into practice. And I'll tell you about one in a second, but you heard about Meltipol already this morning. You heard about the Smile app. You heard about interventions for depression. You heard about cognitive behavioral coaching and medications. Well, I'm going to tell you about another intervention that comes from research today, and I'm going to tell you about how we're implementing that in practice and how we're not just implementing it, but we're studying what we're learning from it as we go. So I'm going to talk about something called measurement-based care. Sounds like a pretty fancy word, but think about it this way. When you go into your doctor or healthcare provider, and when they're looking to check on how you're doing, they might do something like run a blood test, or they might take your blood pressure, or they might run an EEG. They've got tests that tell you how you're doing. Well, in mental health, we don't have a blood test that tells you whether you have depression or anxiety. You've heard today from Dr. Ur and from Sandra, we've got lots of ways that we're helping to understand how people are doing. But one of the ways within our current healthcare system that we're doing that is using measurement-based care. That's asking tested questions of our clients to understand how they're doing in their care, and then using that information to tailor their treatment as we go along. So let me tell you about what this looks like in practice. So when a client comes in to see me in my office, we have an iPad. They fill out some questions for me on that iPad together. That iPad then plots their scores for them over time on a graph. We then look at that graph together. Here's the important part, right? This data doesn't just live with me as the clinician. I don't just take it and make decisions out here. We look at that data together and then make a decision on whether their treatments are working and whether we need to change. Now, this might not sound like rocket science, but I will tell you this was incredibly hard to do before we had some of the technology that we have today. The data up here is actually from one of my patients, and let me tell you a story about why this actually mattered. So this was a client who I had been working with for a few sessions, had been making some pretty good progress over time. If you can see, this is easier. If you can see here, we saw increased progress. She came in at about session 5, and she said to me, you know what, Jill? I actually feel like, although I feel like maybe things were working, I'm getting worse. I had a really bad week. Things aren't working well for me right now. I feel like I just need to give up. I'm going to drop out of therapy. Things aren't going well for me right now. Right? Normally, what would happen in that case is I would try to reassure them. I would either say, like, hey, come on, let's keep going. Let's give this a try. Or I might ask them some more questions, and we might make a decision to change. What I did in this case was actually give them these measures. She could fill out her own questionnaires to get her own data to understand from her own perspective how she was doing. And if you can see on this graph, this is kind of where she started in treatment. This was the session where she wanted to drop out. Right? She thought she was doing way worse than she was when she started. And without this data, I would have thought maybe that she was doing worse than she was when she started. This data helped her see that actually she was improving more than she was when she first started, and gave her the confidence from her own voice to say, maybe we should keep going. And we did keep going. And we kept going over time, and you can see that we improved, right? So there's been a lot of studies on measurement-based care. It suggests that actually adding it as an adjunct into treatment does things like decrease dropout, so it keeps kids in treatment that otherwise might not. It helps them engage in treatment. It gives them a voice in how they're doing. It can also make our treatment more effective because it helps me as a clinician better pick up on when things are going off track, right? So, and this is consistent with a lot of the evidence that happens. So all sounds great, right? Sounds like an important intervention, helps our clients. This put this client's voice at the center, helps them actually be more engaged in their treatment. But here's the thing. How do we keep this from being like our vaccine clinic earlier? Great intervention. I think it's great. We use it in our practice, can make a difference in the way kids are engaging in their treatment. Not so easy to do. Doing this in treatment requires us to make changes in the way that we provide care. Requires me as a clinician to make space in the session for it. Requires the client to understand and interpret that data. Requires both of us to interpret these data together. Many of our clinicians have concerns about what impact will this have on our relationship with our clients. Many of our clients wonder, are you going to misuse my data in different ways? So we have to really pay attention to how we're implementing this care as we go along. And by the way, there's good evidence that if we don't use this in the most effective way, it can actually decrease our sensitivity of care, right? So what are we doing differently to make sure that we don't end up like that needle clinic, to make sure that this measurement-based care doesn't end up on the shelf and not being used? Well, the first thing that we're doing is we're actually applying research to implement this particular intervention. So first off, we use research to help us pick the tools that we measure. So what our clients told us is that they don't just want me to ask them questions, they don't just want questions asked of them about their depression or their symptoms. They also want me to ask, they also want questions to be about how they're coping, what their symptoms are, what their quality of life looks like. We're also using science to help us understand how we best train our clinicians in doing this, right? So we know that group-based training for clinicians as well as individual training is important. And we're investing a lot in how we message this. And it's working. So we are month over month making progress in getting this into practice. So remember how I said there's a 17-year gap between getting interventions from research into practice? Well, we're at about 1.5 years and we're already moving in that direction. And just because something works somewhere else doesn't necessarily mean it works here. So one of the other things we're doing right now is actually standing up research to look at how this is working within our own current context. So what is the impact on our patients and families? What does meaningful change look like for them on these measures? And whether or not we're asking the right questions as we go along. And here's the neat part. By using measurement-based care, it helps turn every interaction into an opportunity to learn. So every time a client comes into the room with us, not only do we learn in that moment, but we have an opportunity to learn as a system and start to answer some of those questions around what treatment works for who, under what conditions. So thank you.
Thank you, Dr. Chorney. Now we have the opportunity to hear directly from one of the young people that we're talking about today. Darius Shepard is here with us today. Do you want to stand up and wave to me? Okay. So Darius is among the young people involved in consultations about change in Nova Scotia's mental health services. He's been kind enough to make a short video with us, sharing his thoughts about his experiences and the new integrated youth services sites or hubs that the province is establishing.
Hi, my name is Darius Shepard. I'm 17 and I live in Dartmouth, Nova Scotia. I'm in grade 12 at Dartmouth High School and I want to pursue a Bachelor's of Science at Dalhousie University, specifically majoring in neuroscience. I believe mental health care for youth is a very important issue. I would say I've experienced low mood depression throughout my time in adolescence. A lot of my friends have also experienced low mood depression and other symptoms like anxiety. I feel like it's hard to stay feeling positive towards how successful your life is in general. A lot of the pressures, I would say, stem from adults. This can range from people in their own household, like their family members and parents, to other students within your school setting or in your social life. In social media, there's a lot of different pressures that push ideals of careers, ideals of how to go about life in general, and things that can range from how you should approach relationships emotionally, physically, and how you should even approach your own finances in your life. Having the option as a young adult and as a youth to access mental health care independently, I feel like is an important step to having better treatment overall, having access, say, through a phone number that you could call even, or a link as in a website or even an app. It is something that I think is a small step towards making this improvement. Waiting months on months and potentially half of a year is far too long for somebody looking to be able to talk to somebody for help. I wouldn't have wanted to wait longer than 3 to 5 days. Having a hub for youth mental health and services of overall well-being would be great. It would be like having like a second community center or a safe place that a youth could go to if you can't help catch and strengthen somebody's mental health and well-being as early as possible. It can cause them to have more and more issues later down the line as they get older.
Fantastic. Thank you, Darius, for sharing. Our final speaker this morning is Dr. Lori Wozni. We are delighted to take just a moment here to announce that earlier this year, Dr. Wozni was appointed as the new Sun Life Chair in Youth Mental Health. The Sun Life Chair was established in 1999 by a passionate group of community members known as the Reaching Out Group, many of whom are here with us today, among the folks, some of the folks from Sun Life. Thank you for the donors and for Sun Life for being here today. With their help, the Endowed Research Chair in Youth Mental Health was born, a role critical discovering new approaches to the mental well-being of youth and their families. Dr. Wozni is the perfect fit for this prestigious research chair. She is a transdisciplinary scientist focused on rethinking approaches to mental health services through the systematic study of possible, probable, and preferable future models of mental health care. Her collaborations span mental health, community health, emergency medicine, computer science, and implementation science. She leads large-scale local and nationally funded research initiatives with a focus on learning, health systems, and health equity. Recently, she received the Robert Bortolucci Award for Research Mentorship at the IWK Health Center. Welcome, Dr. Wozni.
Thank you so much. Thank you so much. Good morning, everyone. Isn't it beautiful to be by the water this morning? It's stunning. I actually grew up near the water, not too far from this spot right here, which is a stunning place to grow up as a kid, running through the rocks and the waves. And one of the really important things that I learned about the world and life living by the water is how interconnected everything is, and how important it is to orient yourself to the bigger ecosystem around you. And so at my house, we had things like tide clocks and barometers, wind socks. This was before the time of apps that did all this stuff for you. We read the weather by the clouds, and we read the Farmer's Almanac, and we tried to pull together all the pieces of information about the wind and the weather and the tides and the currents, so that if we were going to go out for a boat trip, we had to know what was going to happen so that we didn't kind of end up in a shipwreck. And knowing all of the complexities and pieces of how all these things work together is part of what I think I bring to my scientific work. And it's one of the reasons why when I think about youth mental health, I don't just think about individual interventions. I think about how the heck do these all fit together in a system and work cohesively and coherently, so when youth and families reach out, they don't experience this as a giant maze, but something that's very compassionate and supportive and human-centered. And so the big questions for me are really, what do we need to know about the system so that all of these kinds of interventions that we are proving to be effective, journal articles full of evidence saying that different kinds of interventions can help youth, actually make their way into the community clinics and school counselors' offices and emergency departments where youth are showing up. I want to build off a little bit of what my amazing colleagues shared this morning and talk to you a little bit about how the research that we're leading through Dalhousie with our partners is really pushing us to a new era of research where we're embedding it in our clinical practices and we're pushing for whole of system innovation. And I want to talk a little bit first about, you've heard Darius do a great job of talking about what it's like to have a service hub where, there we go, a service hub where youth can access all kinds of different care in one place. And this picture, the smiles and the laughter, captures a moment a couple weeks ago in Amherst, Nova Scotia, where the first of 8 integrated youth service hubs opened. And what's incredible about integrated youth services, it's about bringing mental health supports, education supports, employment supports, and social programming and recreation all together in one location in a community, and co-designing those things with youth. And what's incredibly special about that is that it also has, baked into the fiber of how it works, research and evaluation. And so that gap that Dr. Chorney talked about, that 17-year gap, we're actually able to reduce that because we actually work hand in hand as researchers and evaluators with the integrated service teams. And our new team, our new name, I should mention, is Anchor Youth Spaces Nova Scotia. The promise of this care is that, as Jill Chorney also mentioned, we use the same platform to connect youth and learn about what their experiences are. And we want to make every encounter that we have with a young person that may come through those doors, which may be early in their process, they may be just exploring an issue of mental health, they may be just there to make a connection with a peer, is we want to make sure that we learn from every opportunity. And so having research embedded in that process is really important. And so when youth come in, they do a similar thing. We get to know them, we talk to them, we learn about what their needs are. We do some of the same kinds of assessments that we do in our community mental health clinic, and we use that to guide a process and a plan for them. But we also, as research and evaluation teams, work with the sites and across the network to understand what's happening in the trends across sites and across young people so that we're picking up earlier on things that communities need, on gaps that we're seeing, and also on places where we're having huge progress and making big impacts so that we can scale those to other areas of the province. And while it's still really early days in getting integrated youth services and Anchor Youth Spaces off the ground, we're really excited that we're already able to, because we've built this research infrastructure, we're already able to attract other kinds of research projects that make sense for our local community. Because we know that communities want research that's going to listen, that's going to learn from them, and that's going to act locally, not just publish research articles out in the world, but it's going to support work that they're trying to do locally. And so we have a couple of already funded research projects for the next few years that specifically look at things that community co-designed with us as areas we wanted to work on. So there's a number of youth here over the table actually that are, which is awesome, that are part of the research that we're doing around youth voices and mental health service planning. So they're helping to explore what it is that young people in Nova Scotia really want out of these kinds of early interventions and spaces for them to connect and receive the care that they need. And we have other projects that look at staffing and how do we connect with the staff in these co-located sites to make sure that we can retain them, that they have a good experience working in these co-located environments. Because we know that trust and continuity of care are critical for when youth first come into those services. And we need to be able to have people in those spaces that are working at their best and feeling their best. And so this kind of really rich research ecosystem and environment is allowing us to do all kinds of things that we don't normally do as researchers who tend to sort of study things from a distance, and now we get to work on them together as an embedded team. And this is a really big shift. And we're moving away from that kind of one at a time implementation of different treatments to investing in a whole ecosystem of research and evaluation that lets us adapt and evolve as new evidence evolves. And the evidence is always evolving. And another thing that's really amazing is that because we've invested in this in Nova Scotia, we are connected to the pan-Canadian networks of integrated youth services that is growing and multiplying, and the global work in integrated youth services. And so all of the learnings that we generate from Nova Scotia are now making their way into other communities in Canada and other places around the world. And the things that we're learning are helping them do their work better, and the things that they're learning are helping us do our work better. And it's really phenomenal to see sort of a global learning health system emerging from all of our work. So it's incredibly exciting. But we still have a lot of silos in the bigger world of youth mental health. We have work in education that happens, in justice, in health, in community services and social development. And so we have to start thinking about, is there a way for us to bring together and collaborate at that level in the same kind of way that we're starting to innovate at the service level? And I don't know about you, but one of the analogies that this makes me think about is the different ways that my husband and I seem to think we should load the dishwasher. And I don't know if this is as contentious as it is at your house, it is at mine, but we definitely have two different styles. One I would call kind of free-flowing, a little bit loose, a little organic. And the other, my husband's in the front row, I need to be really careful what I say here. The other one is really maybe a little bit more like oppressively structured and rigid. When your husband worked in the union, is now a politician, debates are really hard at your house. So how do we move forward? When we've got these kinds of places where we're struggling, it's not surprising that we have different opinions about how to do it, but we can get deeply passionate about the approach that we think is the right one to take. And if I scanned this entire room and asked you, what should we focus on to make movement towards a better early intervention in youth mental health, we would all have different ideas, and it would be very hard for us to land on a consensus. But I have a really bold idea that the system needs to find places where we actually can agree on how we move forward, because I don't want to just innovate on the margins. I want us to work at the core of the system in the places that we know we have the biggest barriers. So I want to talk a little bit about I love this picture. I want to talk a little bit about how do we work smarter, not harder, not just harder. And it's about our new Unite project that was mentioned earlier, which is funded for 6 years with Research Nova Scotia. We are incredibly excited about this. It's a really bold idea and a new approach to doing research at a system level. And for us, it's about thinking about how what we do in medicine needs to connect to other areas of science. So we've partnered the Department of Medicine and Psychiatry with the Faculty of Management, where they have incredible expertise in human-centered design, and social innovation, and how you work to develop policies together and how you innovate together. And it's new for us and it's new for them, and we're learning different things about our disciplines and our fields and our research methodologies and our analytic techniques. And it's powering us towards different ways of thinking about how we could address challenges in youth mental health. And along with 20 partner organizations, including the IDBK and Nova Scotia Health, who are also here, and policymakers at different levels of government, and youth advocates, and incredible researchers, we're really putting kind of an all hands on deck focus for the next 6 years on the youth mental health system in Nova Scotia and how we can move towards an ecosystem where we innovate more easily. So we're going to focus on a couple of areas. One is, and you've heard the word a lot today, is the word data. And across education and justice and education and different areas, we collect an enormous amount of information about what's happening with youth, what's happening in schools, what's happening with their friends, what's happening with peers, what kind of programs they're servicing, but we don't look at that data in ways that help us make sense of community. We don't bring that data to community to help them to learn and to digest and learn about their own trends and things that are happening in the community. So we're going to spend a lot of time thinking about how we link data meaningfully and how we have conversations about the really important questions that we think impact youth outcomes. But we're not just trying to build dashboards and look at data and have, kind of put it together and visualize it. We also want to make changes to things that we know are already a challenge. And these things change all the time. We know that there are people that are working within the system all the time trying to create new ways to navigate the services, how to connect youth faster. We all have ideas about the ways that we can do it. So we want to come alongside teams that are already working to build navigation supports and think about how we can optimize it. Think about how we can use different kinds of science to give us insight into where youth are having 3, 4, 5 different touch points before they get to what they need. So we can look at and forecast when we might need to reach out to a young person because we're seeing trends in what's happening that are telling us that they might need to get more intensive services. So we're really going to think differently about how we navigate people, how we support people in the system who are navigators, because lots of people in the system work to actually connect and refer youth so that they understand more about the system that they're working in. It's a really exciting project. We've never really done it before, and we're extremely thankful that we have partners across Dalhousie, outside of our faculty as well as in, that are jumping in to come on this journey with us. Youth mental health is shaped by so many factors, by biology, by identity, by social relationships, by the life events that young people experience, and as Darius shared so nicely in his video, the many complex pressures of our modern world. And initiatives like Anchor Youth and Unite, they show us that research can be a powerful force for reshaping the system and helping young people to navigate these challenges with purpose, with precision, but also with possibility. I'm not saying it's going to be easy, but we definitely have more than a tide clock and the Farmer's Almanac to help us this time. And I believe that if we continue to orient ourselves toward interdisciplinary research and embedded research, we're going to find ourselves offshore, heading off into a future where we aren't just treating symptoms, but we're transforming our system. Thank you very much.
Thank you, Dr. Wozni. A big thank you to all of today's presenters. And we'd now like to invite our speakers to, don't go away, Lori, we're going to come back up for a minute or two, to join on the stage for a Q&A panel for a few minutes hosted by Laura Egertson. Medical Research Communication Officer at the Faculty of Medicine. This will be an opportunity to delve deeper into topics discussed and exchange with our experts. So please, all of our speakers, Rudolph, Lori, Jill, Sandra, please come on up.
So just while we're getting up there, I just wanted to say that was a really great talk from everyone. I think we're all in agreement about that, and I'm sure there are lots of questions out there. So my name's Laura Egerton, and I work with the Faculty of Medicine's advancement team. And my job is often to talk to all of these researchers and hear about their stories and then tell them to all of you. And now we've got a chance to hear from them ourselves. So there will be somebody, oh, Emily in the back has a microphone. So if anybody has a question, if you want to put up your hands, and while she's finding somebody, I'm going to start us off. I just wondered if all of you could talk to us a little bit this morning about, first of all, I found that a very hopeful presentation, especially hearing about some of the new research that you're creating. I'm wondering, maybe Dr. Uhr, can you start with how do you get that important information about personalized treatments for depression and anxiety, for example? How do you get that, using Lori's example, into clinical practice? What's your plan for doing that?
Yeah, so I'm a researcher and psychiatrist, right? So I'll be cautious here, not too early, right? That's why we're running a trial to test it out. There's been a lot of premature implementation of things that look like they will work in a small research study, and they didn't then, right? And we don't want to have that medical reversal that keeps happening. So when we know it's working, then we bring it in. And there's different levels of bringing it in, because if it needs an MRI scanner, it will not happen, right? If it needs a portable EEG, it may happen, but it needs investment. If it's just the kind of questionnaires, the measurement-based care example, that's quite easy to bring in. So you need to make decisions that are proportional. The amount of benefit or the amount of investment, both in terms of technology and time, when that balance is positive, and we know for sure that's the time to implement, that's why I'm talking 10 years, not a year from now. It will happen.
Jill, do you want to speak to that at all as well?
Yeah, I mean, I think one of the other benefits is one of the pieces that you hear, I think, about a lot of this work is how we embed research into care and don't actually have these artificial distinctions between research happens up here and care happens here. So I think research is care, and I think that's what you see in some of the trials that Dr. Uhr is doing. I think that's also one of the things you see in how we embed research into our decision-making processes within our health systems as well. So one of the things that I'm really excited about is as we move towards these things called learning health systems, it's how does research show up at our decision-making tables every day? So how do our managers, how do our directors, how do our leaders, how do our policymakers understand research, and how are we conducting research that matters to them so that it can drive decision-making as well? So I think it really is about marrying research with clinical care and with our system decision-making, and that's where we're going to have impact.
Do we have any questions on the floor yet? Up here? And just while we're doing that, maybe Sandra, can you talk about, I know people are going to be very excited about those apps. How can people start to get access to that? Is that available yet, or what's your plan for rolling that out?
So this is the first time that I'm a very strong science-based person in genetics and things like that. So this was my first endeavor ever doing something directly with patients and kids. And so we wanted to find out, actually, does it work? Does it even make sense to develop another app? Because as I said, there are a lot of mental health apps out there. But now we know we seem to actually trigger something in people that they really like. This personalization seems to really help them. And that's why I think we want to especially work with the clinical teams together and see how can we bring it there. I don't want to replace in-person therapy. Don't get me wrong, I think what you're doing is awesome, but I just want to bring you something in the hands because they cannot see their therapist every single day. So when my app can help them a bit, oh, what did my therapist say? Oh, I should do this today, and just helps them with reminders and actually brings it more to their daily life when they can't reach their therapist. That's a little bit my goal. how can I use this to help clinicians, and especially also the conversation? Like I work a lot with kids who are not like that super in expressing what they want, and mental health apps can just help with that because you can actually give them some data that is not about talking. That can just help the clinician and the kids to actually see graphs and then like say, oh yeah, I want to be here with my sleep, for example. Okay.
Okay, we had the question here. Go ahead.
Yes, thank you. First of all, thank you for the insightful presentations. Very interesting and very important. Really enjoyed that, and I think I'm speaking for everyone here. Yesterday, I had lunch with an artificial intelligence savant friend of mine who mentioned the fact that he's now finding that through AI, he has access to effectively what he deems as the best therapist in the world at any given moment. I didn't hear AI mentioned today. I'd love to hear your thoughts on the opportunities and the limitations there. Thank you.
That's a really good question. Does anybody in particular want to start that one? Rudolph?
I'm happy to take that. Yes. So I mean, there are things that become very popular and that are always overblown and look like they will make huge impact. And the use of AI is one of them, right? When I mentioned biomarker-based algorithm, I could call it AI, right? It's machine learning, deep learning based. But the chatbots, it's like look at how the engagement and how it lasts over time. So I think there's a place for it, right? And the advantage is a very rapid possibility of engagement. You can get chatbot or AI interface immediately when you're searching 1 a.m. Not recommended, but often done. And you don't need to go through the process of accessing medical treatment or psychological therapy. So there's place for it. Typically, both the benefits and the engagement are short term. There's like when you open ChatGPT for the first time, it looked amazing, right? When you use this for a few weeks, you are able to start recognizing what's written by a human and what's written by ChatGPT. The amazement is gone a bit, right? And that happens in each way because then it gets better. It's a little bit exciting again. Then you realize its limitations again. That's the cycle, right? Where it's making difference in medical research and medical practice now, it's like ambient scribes. It saves time. It saves time writing notes. That's the application of AI that really works. The AI as therapeutic agent, I don't think that's a serious player anytime near.
And maybe Lori, could you add to that a bit about, from your experience when you talk to the youth in consultation about the hub, for example, they had some thoughts, I know, about wanting some personalized interaction. Is that right?
Yeah, I mean, I think like all of us, we don't want mental health treatment to feel like we're just kind of getting, your box set of things. You want it to feel personal to you. You want it to feel connected to the needs that you have. And I hear a lot from the youth that I work with that, youth isn't one voice and there are many things that youth want. There are many experiences. They have diverse ways of wanting to approach treatment and therapy and their own understanding of mental health. So I think AI is one of those things where, again, I think there's a curiosity, but I also think young people appreciate human connection and being able to be with each other and spaces for them to develop relationships with human beings. And I think it's the balance of there are places that you said where it can have a huge impact, but also it's not the only part of their lives, and it isn't the only mechanism and vehicle that is going to build resilience for them and help them address their concerns. So I think there's an interest and a curiosity in thinking about what it could look like. But I would also say, and even in my own young people in my own family, I think a bit of a healthy skepticism and a desire to really understand what does this mean and what does it mean for society for us to do that. But I think they're very balanced in the way they think about it, and they don't want something that's boxed. And where AI can help personalize information to their very specific needs, I think there's probably a route for it to be valuable.
Perfect. Do we have any other questions on the floor? Over here, yes. That's Dr. Bartoluzzi.
We've all just come through 4 years of COVID, and probably the most vulnerable population for the social disruptions are teenagers. And we're probably just starting to learn the effects on that. Are some of the tools, some of the strategies you spoken about, can they be applied for the anticipated changes in teenage behavior as they enter in adulthood? Thank you.
So if you like, I can answer a little bit around social media, like how social media and screen time actually have changed lives of kids a lot. So we know that during the pandemic, actually a lot of life transitioned on screens. And on one hand, that was good and bad. Like what I would say is always, there's a lot of change in that, but it's how you use social media for the good or worse. Like we see when actually youth, especially like youth who might not feel that represented in their direct environment, use social media to connect with others that have similar ideas, it's actually pretty good. Or when you play video games and you do that with your friends, I wouldn't say that it's bad. It's more when you start constantly comparing yourself to others. I think for some people, it's also like I work at the moment in eating disorders. A lot of the stuff that we see is very healthy and very thin people. And that can be very bad. But there's also very good social media accounts who actually show body positivity or that your body is a lot of things, not only it has to be thin, it actually takes you places. It can feel the grass under your feet, all of that. So I think that is something that I would say we have to work on. Use the technology that we have used during the pandemic, but use it in a good way so that it's aligned with your values and with what you want to achieve. And I think that's something we have to work a little bit on it, like that we see it not only as a threat, but also all its potential. And it's very individual for every single person.
Jill, did you want to add something?
Yeah, I think one of the themes that you're hearing up here a lot is the need to be adaptable and the need to change with changing times and changing. And I think all of these tools that we're talking about, whether it's how we use data to understand what's happening with our youth, whether it's talking how we use measurement-based care to put youth voice at the center in their decision making, whether we're talking about having alternate versions of different ways that we can intervene, I think the key going forward has to be flexibility. We're hearing a lot about youth lives are becoming more complex. Our systems are becoming more complex for them to navigate. So I think as we go forward, making sure that we're taking advantage of bringing things together so that we can be adaptable and responsive to changes in youth lives and in our environment is the important key going forward.
Okay, I'm getting the signal that we have to wrap it up. I'm sure that some of the researchers are going to be available afterwards, and so I would encourage you to go back to the tables as well, and I'm sure they'll be around. Thank you very much.
I'm just going to take 1 minute while they're taking the picture here. We've got the picture. So I'd like to take just a moment and I would like to thank our sponsors, Shanex, Dalhousie's Department of Medicine, and the Kids Help Phone. Thanks as well to all of you for your presence and support today. Donors are crucial in advancing youth mental health research and interventions. If you have time, and I realize we're a few minutes over, you're welcome to stick around, look at some of the booths, talk to people. You'd be more than welcome. Also, don't forget to pick up your copy of Remedy. You can read about other research as well. Cooperatively, we would encourage you to take the flowers amongst yourselves. And there's a lady at the back who, in the back room on your way out, that will wrap those flowers so you can take them home and share them with someone. That will brighten someone's day. So thank you and enjoy the rest of your day.